Okay, so again, I'm Jim Mulshine, and my co-moderator for this ethical and legal considerations for communicating probability for future events is Rowena Yip of Mount Sinai. She is our hostess for this event. And we need to get a few more panel participants. Cheryl's coming right back. And Doris. It happens. Okay. So what we're going to do is we're going to get started. There we go. Thank you, Cheryl. So we're going to get started and try to do this in an efficient way. What I'm going to ask all of our panelists, our distinguished panelists, to introduce themselves and then potentially tell us the single most important issue they have been struck with relative to the ethical and legal considerations in the material that we've been discussing for the last day and a half. So if we want to get started, David, not to put you on the spot.
So testing. David Maron, I'm a preventive cardiologist at Stanford. And it's hard for me to say what is the single most important. So I'm going to take the liberty of listing 5 things. And hopefully I'm not stealing anyone's thunder. Number 1, this is about communicating results. I think that there's an ethical and legal responsibility about communicating results from the radiologist to the referring physician. That's number 1, or maybe not number 1. Number 2, I think that there's a responsibility to communicate results to the patient. And number 3, I think we need to be mindful in that communication about the potential risk or harm to the patient of inciting a lot of fear and anxiety. So I think that the messaging needs to be carefully crafted. And then number 4, I think that clinicians have some potential liability if they don't communicate results to the patient. And then last, I think that there is a health system liability. If there is information in images that have been obtained from the patient, gone into the medical record, and not communicated to the patient without clear documentation, because I know we've been talking a lot about coronary calcium. Patient's got severe coronary calcification, is not aware of it for any reason, lots of different places where the system can fail. Patient has a big MI, develops heart failure, has bad quality of life, a shortened life. And I think that the health system and clinician who knew about this is responsible, including perhaps the radiologist who didn't document the presence. So I'll stop there.
Wow. Wow. So we could spend the whole session just that, but
Sorry.
We'll go on. Glenn, could you just please?
So good afternoon. My name is Glenn Martin. I'm a local boy from Sinai, and I head up the IRB system. But I'm actually a psychiatrist, which may or may not be useful today. So obviously my expertise is more on the research end of things. But when David was speaking, I was thinking one of the issues that I do think is worth discussing is sort of the concept of informed consent, which is obviously a really big deal on the research side of things, but is much less of a big deal on the clinical side of things, especially since a lot of the radiology things that go on don't require specific informed consent whatsoever. And the informed consent that does occur is going to be of the more clinical, it's good for you, I think it's a great idea. You may mention a risk or benefit. I'm saying everyone does everything properly, but there's not a long and detailed discussion. Whereas if you were going to use some sort of experimental CT or whatever and give results back to the patient, there would be a long thing about the risks about wild goose chases, unidentified glowing objects, and all of the issues that come up. So I would suggest that one of the problems that we're probably grappling with is that what we think patients should know, want to know, and will know is not necessarily what patients expect or even want to know, and how to handle that. But at the same time, making sure that especially actionable information is made available in a way that people understand and actually improves their care, not freaks them out and makes it more difficult for them to get care. So in general, those are some thoughts. New York State has its own interesting rules about this, but as long as your tests are approved by the FDA or by Wadsworth, which is the public health lab up in Albany, then you can return results. Otherwise you can't. It gets complicated. I doubt that's where it's a sideline will go into. So I'm looking forward to it, and thank you for inviting me.
Thanks, Glenn. Doreeth? Oh, I'm sorry. Could you please introduce yourself? And then could you just go into what you think is the most important issue along the lines of the ethics of communicating about these tests?
Okay, so I'm Dorit Shaham. I'm a radiologist from Jerusalem, Israel. I was Claudia and David's fellow almost 30 years ago. And I started the first lung cancer screening program in Jerusalem, where I practice. I know that, okay, and the one thing is that we had the national pilot program for lung cancer screening, which is just ending these days. And we had discussions about this. So some of the people involved in this thought that we should only report on things that are related to lung cancer, and they didn't want us to go into, for instance, the coronary calcifications. People who were like the management of the program, they are clinicians, but they are not, they are actually the person who insisted on this was a family physician, but he's a manager, not, I think that as radiologists, we are obliged to report on each and everything, but I think that the ethical aspect of this is what are we going to do with it? And I think that we have to specify. So if this is the finding, this is what needs to be done with it, because we can't just pour out whatever is in the image and not relate to it. So I think we have to mention things that are, we also had discussions about incidental findings, how much we have, I mean, incidental in a way that like a thyroid cyst or a renal cyst or things that don't really matter. Do we have to report on it or not? I think we have to report on things that have implications, but we also have to tell the patients what to do with it.
Thank you. Thank you very much, Doreeth. Lee?
Yeah, my name is Lee Goldsmith. I am graduate of NYU School of Medicine and NYU School of Law, and I practice strictly in the field of legal medicine. And by doing that, that has multiple implications. And I look at a meeting like this and say, rather than the negatives, which I hear all the time about physicians being sued, which is part of what I do, to turn around and say the other way, it says, what can the legal system do to promote your interests and get what you want accomplished? And I think there are ways that can do it. It may be distasteful to a number of you, but I think it's important because from the very beginning, you talk about the legal implications of not giving an informed consent. That's there. But I think it's more important to say, how can we use the legal system to get the patients in to see you so that there's less of a need for legal involvement? I should start from there.
Thank you, Lee. Cheryl?
Thank you. I'm with NYU and I studied at Columbia University. I think what strikes me most are some of the macro questions, and that is screening at the present time fairly distributed with respect to access? I think the answer to that is a resounding no. Do AI systems for screening, particularly the types of screenings that we've been discussing at this meeting, do they have built-in biases when they're being operated within the context of of an AI system, either in terms of how the tests are interpreted and whether the interpretation, the comparator for the interpretation is a legitimate one or one that may have some inherent biases. And the same for the follow-up steps. In other words, whatever is implied by the findings is who gets the follow-up steps and the associated clinical workup as appropriate. Is that happening? One, and is it happening differentially? Two. And I guess finally, can the healthcare system, especially in a country that truly does not yet have universal health access, as the rest of the industrialized nations do, can the health system legally be held accountable for assuring that the above happens in the right way instead of the wrong way? My reading of the Cures Act, which I quickly just looked up the section on this, and I'm sure you all know it by heart because you work within the system and need to know it. I mean, as far as I read it, the level of disclosure is massive. I mean, the exceptions are exceptionally narrow. And so any incidental finding that might otherwise have been just sort of ignored because it didn't seem particularly actionable, I think it has to be reported. And then that gets into, glad we have a psychiatrist on the panel. You know, if you're to inform someone about 4 pieces of bad news out of one scan, I don't know what the literature is on that because one of the exceptions is harm to the patient. And I do think that when people are having tests, the result of which could be extremely bad news, you know, that the consent has to have that in the context. We were talking in the off session earlier today about the role fear does play in these things. And so the downside of that is you might lower slightly the acceptance rate of a screening procedure or genetic test or whatever because of people's anticipation of what a negative result would mean to them and how they would react. But anyway, I think it's all very complicated, but that's my thoughts.
Okay, thank you very much, Cheryl. So you've touched, the next question we had was about the Cures Act. And just to put this in focus, in the last week or so, I think people have been reading about the FDA guidance on density in mammography screening. And FDA came up with very, very straightforward mandates that if a woman has density on mammography, it has to be explained, not only in depth, but it also has to be a conversation that includes options for best management. And if we're doing that for density mammography, which is a very important thing, by analogy, what do we need to do in cardiovascular disease, lung cancer, and emphysema? And so one of the questions, the angle of the question that I'd like to present to you in discussing these mandates and these Cures Act and this FDA mandate, stuff like that, is do you think there's an opportunity for some of the professional societies or other agencies or advocacy groups to start pulling this together in resources, white papers, that the primary care community can access as resources to help with the burden of all the potential things that may be uncovered in the course of a thoracic CT? David, do you want to start?
No. But
Okay.
I think that we do need to, the preventive cardiology community needs to create tools for patient education, physician and clinician education. And they would include explaining what the risk is associated with the finding. And as was pointed out by our attorney physician, what they can do about it. As Jamal said in the previous, having a care pathway. So you don't just drop a bomb on a patient, but you provide them with good information for follow-up. I don't know if that answers the question, but that was what came to mind.
Pretty good. Thank you. Thank you, David. Glenn?
So I was just thinking, in my psychiatric life, I spent a ridiculous amount of time on the DSM steering committee and the like, which is our society's effort to come up with diagnoses that the world would use and understand what the criteria are for psychiatric disorders. And I was sort of thinking when you talk about the role of professional societies, certainly guidelines and white papers can be extraordinarily helpful, if only to make you feel a lot more secure that what you're doing has the support of your profession. Ultimately, though, it's still the regulators that are going to decide to some extent what it means. And I would just put down the caveat is because we chase after this in the IRB, where it was sort of return of results of genetic information. And one of the societies had put out a list of sort of actionable genes, which is great, but it probably gets updated every 5 minutes now. So you end up trying to put down guidelines that are flexible enough that you don't get tripped over the first time you sort of implement them would be the concern. But obviously having a consensus behind you is very helpful, though you can still end up in the situation where the regulators say one thing. That's it.
Okay, thank you. Doris?
So we had a discussion, I don't remember the other day. And so in the low dose city, we have many findings. So potentially many specialties have to deal with it. And then we leave the patients to navigate by themselves, you know, if they have to go to the cardiologist, if they have to go to the hepatologist or whatever, a general surgeon. And I know that I was talking to Claudia, and I understand that probably this cannot be implemented in this country, but in Israel, we have national health insurance. And the people, the physicians who navigate among all these specialties are the family physicians. And we had a meeting with the society. So some of the leading radiologists in the Israeli lung cancer screening program, we met with family physicians. And we found it very helpful because they can really, if they are good, some of them are not really family physicians. They are just general practitioners. But if they are good, they can really help the patients navigate among this. So this is one society, at least in my country, that I think it would be helpful to discuss the issues with them, and then they can help the patients and refer them to other specialists as needed. But they can also follow what each one of them is recommending and reconcile in case this is needed.
Great, thank you. Lee?
Let me get to the issue of informed consent. It's a number of things. The way we look at it is, what is your duty to provide the patient information? And then as a lawyer, I look at it and say, what information was provided to the patient and what was the effect of not providing or providing that information to the patient? Because if it had minimal effect, then there's no basis for a lawsuit. If not providing information as to cardiac calcifications, which led to non-treatment, which led to a cardiac event, then you have potential for litigation. But let's put this into perspective also. We know from statistics that only about 1 in 50 acts of malpractice ever end up in litigation. So the responsibility of providing the information really falls upon the practitioner to get the patient cared for. Because we as lawyers can't really push you to do that. All the litigation that I've seen on failure to diagnose cancer, the end result, how many cases actually get into litigation, and how many attorneys are capable of handling that case, and how many ever result in getting the patient any money? So we are a little bit of a stick, but it's a very small twig.
So humble. Thank you. Cheryl?
I'm finding myself having more questions than answers on this panel. So I guess I would just say that one of the questions that I think really is just sitting there begging to be answered based on the last 2 days is what can be done to ramp up this type of screening? And what are the ethical and legal implications of failing to do so? Especially if you think about the fact that if under the new guideline, which still is a substandard guideline, let's just think about lung cancer for a minute. And this statistic we heard earlier, I don't know if that's a contemporary number, that 18% of people have had annual screenings or any screening, but let's assume it's optimistically, it's annual screening, and it's 18%. And it may well compare favorably to other types of screenings that are actionable and important to have. Most of them are, I would assume. The question is why, why are there 82% that aren't getting it? How many people are dying unnecessarily? And I'd be curious to see what you think the fate of this class action. I think it's a class action suit or some equivalent that's been going, certainly advertised for in New York City, and I mean, in Washington DC relentlessly about failure to, if you had a lung cancer diagnosis and you were in any primary care system and you did not receive a CT, that's the assembled class. And the ads, like we're running like literally 10 times a day on all the main channels there, trying to assemble the class. So, I mean, I would assume there's real risk here. There's moral injury, but there's more than moral injury. There's possibly, malpractice that would succeed.
Very important point. Lee, did you want to say anything about that?
Yeah. Class actions are something which are of interest. And the attorneys who are doing them are trying to accumulate as many individuals within that class in order to propagate the lawsuit. I'll go back to one of the points you said, there's guidelines. Who is going to enforce the guidelines that are given? The answer is generally they're not enforced. And there's not oversight as to getting people in the guidelines. If that were the case, then more and more people would be screened because everybody who is promoting the guidelines would enforce the screening to take place, which is not the case. Because again, that boils down to, if there's screening, it costs money. And therefore, the less screening there is, the less is the potential cost down the line. Now, class actions take a long time. And one of the things that came out of this morning's session, which I was thinking about, is the fantastic results as reported by the Kaiser representative and the numbers and the reduction in problems that he has. What about a class action using that as a basis, saying why doesn't everybody else have the same statistics?
Okay, thank you very much.
So based on the answers that we got from the panels, is it fair to say that depending in deciding what to add to the report and what our additional findings is all depends on the seriousness of the illnesses, and also we only report the additional findings when there's actionable, when they are actionable?
I would agree. And was there a question there?
No, just,
Oh, yeah, so, any comments?
nope.
If you're talking about the Cures Act, and I read it quickly, I think you have to report everything. Even if it's incidental and even if it isn't actionable, unless I misread it. You have to at least provide the raw data, if not some interpretation of it.
So our next question is, at the policy level, how does issues such as those embedded in the recent Cure Acts impact the topics of lung cancer screening?
Just repeat the question. Can you repeat the question, Rowena? I'm sorry.
This is a question that we put together some months ago. And so there's a lot of concern about.
They can't hear you.
There's a lot of questions from both directions, over-reporting, under-reporting, getting people on my charts to get a 27-page CT scan radiology report. What do they do about it? All these other things. And so the net effect was ennui. I mean, nothing happened. So now you have potentially the Cures Act saying that that's not an acceptable circumstance. What do we need to do about this? And from an advocacy perspective, is there a place for advocacy groups to come together, professional societies to come together and say the status quo is not working and we need to do something else. Is that a reasonable tact to pursue?
I really don't think I'm qualified to respond. Someone to my left. But I will say that I do think, and Claudia had asked me like for ideas, having patients as part of this panel, part of this program would be a really useful addition. Okay. No comment.
Well, I wasn't sure. I thought in the question you just asked, you were asking, is the status quo as embodied in the Cures Act and interpreted by various states, which I see as a open book medical record? What are the additional obligations that go along with that? I think your point, if you have a 27-page radiology report, that for the average patient is probably essentially useless. You have to then in the King's English say, what does it mean and what matters about it? And so that's where you have the opportunity to say, and all these other findings that are in it, they're there for you to peruse, but they're not relevant to any action. And I think it's a big task, I think, unless unless AI becomes the answer, which was the last panel. And I'm fine with that. I mean, my experience with AI is every time that I put a question in a little box, I get an absurd answer. So I think it sucks from beginning to end, but it must be working somewhere.
Yeah.
But in my own life, it hasn't worked yet.
So Cheryl, you wear a couple of hats. You have a policy expertise. We heard about that yesterday. But you've also understand lung cancer at a personal level in a
That's
different
right.
way.
Yeah.
What's your expectation as a screening participant?
Well, my expectation has always been met by David and Claudia, which is that soon after I have my CT, I'll find out anything relevant, and I do. So, and I decided to start screening in 2000 at the first time I sat and looked at the data. And I didn't need a randomized controlled trial to interpret the data. I think the data was an open and shut case then. Truly an open and shut case. You know, we never had a randomized controlled trial to determine whether or not smoking causes lung cancer. So I'm glad the gold standard of the RCT is being looked at a little more carefully. Sometimes data accumulates in epidemiological form that's irrefutable. Not always, but sometimes. So I'm satisfied, totally. But I don't know that I get the full report. I don't know. I get a report. I mean, I probably will get more in my chart if I was generally seen at Mount Sinai, which up until now I haven't been. Pardon? Yeah, I mean, I get a report, but there may be more out there if I were a registered patient. That's all I'm saying. So if I wanted to become registered, I might get more information than even you provide me. But, and if the answer to that's no, fine, then it's no. Yeah, I think it's, you know, it's scary. It's scary to get scanned. I think there are people who, you know, I think some of the 82% that aren't being scanned have been offered a scan and said, I don't want to know. I don't care. They have beliefs that to me are somewhat unusual. A lot of people believe in religious determinism. I mean, a lot of people who don't vaccinate think, you know, when my time comes, my time comes. It's to me a very odd framework, non-proactive, but there are people who subscribe to that.
And Glenn, do you have a comment?
Yeah, I was just reflecting on the fact that your concerns about sharing lots of information with people who won't understand it is no different than any other field of medicine. I mean, in psychiatry, we were concerned about people reading notes where we actually used the word schizophrenia.
Yeah.
And told our patients you have schizophrenia, which not everyone did, certainly years ago. You wouldn't, and you sort of kept very discreet what you thought was appropriate to share or not. Now everything is shared. And now you're dealing with training a whole bunch of doctors on how to write diplomatically what they normally would have written notes for themselves are now writing notes for audiences. And it's the same thing with writing interpretations, it seems to me. Your field is a little bit different because you go on and on and on in your interpretations. Laboratory pathologists don't. And forgive me for saying it, but you know, in the limited number I've read, is that your field also tends to, and always has, put down the speculations that you've noted and then put down, suggest correlation with clinical findings and follow-up is required, which as a non-radiologist was always frustrating to me. As a patient, would it be even more so, but it's just the situation that we're in, that patients have a right to look at essentially anything that's in the electronic medical record for all intents and purposes is theirs to look at whenever they want. There are the exceptions. There's a harm exception, but I can tell you certainly in New York State, how they've interpreted for psychiatry, because that's always existed, is there is no harm unless you can really demonstrate an immediate harm in the near future. Like you really think the patient is going to go out and hurt themselves immediately. The fact that they may be demoralized, depressed, bummed out, or concerned is not going to reach that threshold. So I think the general expectation is people will read whatever you write and the like, which then raise the other issue is what's the obligation that people should understand what we write or have an opportunity to discuss it and the like. And as I mentioned earlier, do they have any idea what they're going to see? Believe me, my wife had absolutely no idea that her last mammography that somebody might notice her heart calcium and say something, or not. I mean, I have no idea, but they could. And she said, "What do you mean? No one asked, no one told me, no one asked me. I had no idea." I said, exactly. So I think that's on the informed consent. We're dealing with a population that has no idea what you might be writing in those things, which makes it more difficult to determine what you would share and how you would present it.
If I may add, there's also a benefit with my chart and similar documentation. It puts the physician in the position of getting the information to the patient in an indirect manner. One of the very first malpractice cases that I was ever involved with involved a physician who got a report from a radiologist indicating that there was lung cancer and forgot to tell the patient about it. So she was not informed for over a year. This way, the information automatically gets to the patient and obviates the potential problem of a lack of information being disseminated.
So I think, first of all, in my opinion, we do have to ask the patients what they want to know. So some patients will want to know a lot and some don't want to know. So I think we have to respect this. And the other thing, and I was thinking a lot about this, that for the lung cancer screening report, I think it has to be understandable, of course, but also not too scary. I think that the way it is now, I'm not sure that people really understand what it means. And I think sometimes we just scare them for nothing. So
I don't understand how a patient who would voluntarily undergo screening for lung cancer would not want to know the results.
no, I don't mean the results of the lung cancer screening, but of the additional findings. So do they want to know every little detail, or do they want to know just the big picture, or?
Yeah, and I'll just editorial, if I may. They don't seem to care. We're talking about an incidental finding that is related to the #1 cause of death. So I think it's a lot different than a 2-millimeter lung nodule.
Right, I agree. I think that when we specify each and every little lung nodule, I'm not saying that it's a lot of work for the radiologists who don't have, and I'm not sure actually that the AI system will address this, but it's very scary for the patient. I had a screening many years ago. She was actually a psychiatrist, the same patient. And I wrote in her report that she has a, I don't know, 2-3 millimeter calcified nodule. And I was teaching students. She was waiting outside of the classroom to discuss, because she was really scared about this. She didn't know what it meant. And she's a professional, and what would a lay person think? And they don't have immediate contact with the radiologist. So we have to think what we're putting into this report.
And we have a question from Sam.
Opposite direction and see the reactions. A cardiologist orders CAC evaluation, gets the result back, and in that CT report, there is a 7-millimeter nodule. What's the workflow that happens from that? And how do you think that the cardiologist would manage that?
So you have to wait for the next session because I have a similar case.
So should we wait for the next session? No, I would say quickly that at my institution, the radiologists put in their report a default, what the Fleischner recommendations are. And that's what I follow. So I talk to the patient. And one other thing is when a patient has a very significant finding on their radiology report, I don't just let it go to the patient. I call the patient to so I can put it into context and provide some, important follow-up instructions. But I just follow whatever the Fleischner guidelines say.
Quick question. In regard to Lee's comments that we have a small role, I think you, being the legal force, could play a good role as, for good. Meaning, once the hospitals and major care providers realize there is actual liability, once they realize there is actual liability in not doing it, and there's a few successful lawsuits, brought them to justice, it will have a major impact. It might even have more impact than all the 30 years work we did on bringing guidelines, calcium score to guidelines. We're actually considering a class action lawsuit in Texas because we passed a law, the current calcium score should be covered by insurance companies, and about like 80% are evading and denying, and patients are forced. And one of my employees, mother was forced to pay out of pocket $250, and she pushed back and said, there's a law here, it has to be paid. And they said, well, our insurance is not covering, take it or leave it. So I think you guys have, in the profession that you are in, have the potential, as much as we have done, to make a change and make it sustainable.
I totally agree. And that's one of the things that I meant when I started this very sessions is what is the role that law can play in enabling the benefits of care? And that's one of them. I will say that speaking of my legal part, most of my colleagues don't have that foresight. And they look at what is the easy buck that they can put into the pocket. It's that failure to diagnose the lung cancer, which leads to the death. And that's easy. The lack of screening, there have been very few lawsuits relating to lack of screening that lead to problems. They don't have that foresight or knowledge. But I do see a role, and that is one of the roles that lawyers can play in this. The question is how, and they do it.
Dr. Weiss?
Is that a microphone on?
Hello, yeah. So this may be changing the topic a little bit, but it's the aspect of the communicating probabilities of future events that kind of keeps me up at night. And so I'm glad that there's a psychiatrist on the panel because I may need help on this. But, we have these large databases out there and we have this wonderful technology of AI. And we're starting to see these prediction models come out. And I see article after article predicting that we can throw your scan in and we can tell you whether you're going to die within a year by X probability and your probability of dying within 6 years. And it's got all the issues of black box and everything else. But there's this whole thing about risk prediction models. We use them for a lot of, we use them to decide who gets screened. We use clinical, those don't get approved by the FDA. You take a big database and then you validate it against another database and you publish a few articles and all of a sudden that model becomes the accepted standard for who should be screened. Well, now there's these new AI models and you see this now, for example, with the Sybil model. This is the MGH that's going to predict, this takes your scan and says, what's your chance of, getting a lung cancer in X years from now? And it comes up with a percentage. And then they validated that with the NLST data. They used the NLST to build it. Now they validated it against a couple of others and they're publishing that. And places are now talking about using that as the standard for deciding, to keep people in screening programs. But there's no FDA in this. All of these rules are incredibly gray. I just spoke with somebody literally during lunch to say, what's the FDA's opinion on how to do this? And the answer is, this area is totally gray. We don't really have a standard. So AI is going to be starting to develop these kind of prediction models to say, you're going to die. Your chance of dying within the next X years based on your CT scan is such and such. How do we put that in a report? What's the evidence needed? I mean, this is just a tremendous ethical and legal challenge.
Yes, so.
That
Who's
was,
going to answer this for us?
that was gonna be my next question, so. And I
Okay.
guess I add to it, it's, yeah, maybe I'll let the panelists answer.
Well, again, I'm struck by, yes, admittedly, AI is its own interesting and somewhat annoying complication. And I'm not a big fan of black boxes. And that's the main reason, if you don't understand how it got there and you don't know if you trust it. But we do predictive modeling all the time. We've been doing it for decades using numbers, not AI. And it tells you have X amount of chance of a heart attack, therefore you're going to get a statin, or at least that was one of the theories of it. Or yes, you have a 5.4 score that says, yes, you probably get a biopsy to see whether or not you have the fatty liver that's going into something or not. So we've been dealing with this for a long time. And it's not a whole lot different than the AI piece, other than the fact you may not trust it, or there may be a higher level and the FDA is showing its own ambiguity in when it wants to step in and actually treat it seriously and when it will show, what's the term, enforcement discretion, and not. But I think it's the same, qualitatively, it's the same issue. It's just a question of just what your level of agreement is with the model and how much you trust it is how much you'll let it guide. And that, I think, is the unknown. We just don't know how much you trust it yet. But we've been doing this for decades. It's just a question of now we're doing it in something much spiffier than we used to. But it's the same basic problem.
And maybe just taking it one sides to a side. So at legal considerations for communicating, but what about non-communicating? In the future, I think this is inevitable. We're going to have more predictive algorithms. So maybe today's normal scan might not be normal. And once the patient develop cancer, we can retrospectively look at it, put it through some kind of an AI algorithm, and here it is. We could have predicted it. What's your view on potential legal implications of malpractice? Should we somehow redefine the misread?
You don't have thought about that.
Redefine the misread is what you're referring to. As of now, the cases that I have seen over the years is that, again, it is the subsequent radiologist who's looking at the film, who's opining on the read of the primary radiologist. And depending on what it is, it may be a misread, and it may be a lack of information. Now, the problem that I get from both sides of the fence is, who is saying that this is a misread? Obviously, the primary radiologist who's read the film says, I read this correctly, this is not to be discussed. And the second radiologist who's reading it says, no, this is something obvious, it should be there. And there are, let me put it this way, just as there are in medicine, there are good lawyers and there are bad lawyers. And there are good testifiers and bad testifiers. And there are honest people and dishonest people. There are many misreads. There are a lot of reads, and especially what I'm seeing now is with radiologists who are expected to read maybe 100 films during the course of a day. I see this especially in mammography, that there's no way that they can possibly read all these films. This is where AI comes into play. And the proper use of AI, I think, will help eliminate a number of the failures to diagnose or properly read the films, properly used. So in a way, I am looking forward to the more use of AI, because I know now from seeing and conversing with everybody that there's reliance by the physician on the AI, that they don't look at the film if the AI says it's not there. Then that subsequently, and I had a conversation when we were in Madrid last year, is what is going to be the liability of the company that produces the AI that is reading the film that the radiologist is relying on? And this is the potential that you could say that the AI is not competent to make that diagnosis, let alone have the radiologist rely on it. So it's a morass that's evolving, but that's always as law is. We're a morass.
Back to the question, so let's say from today's meeting and last 2 days, everybody got ironclad evidence that you see calcium score in existing scans, that person should be treated, it should be flagged, the same way David is doing at Stanford. Would this lend to a legal case for all other hospitals that have my scan from 5 years ago, 10 years ago? Do they have responsibility to run this AI and alert me?
Okay, the answer is, in the individual case, the answer would be yes. Could we convert that into a class action and say, because of this one case, everyone is involved? The answer is probably no, because it is an individual situation. If there is, to create a class like that may be very, very difficult in my mind. No, that's,
I'm not a lawyer.
but that's,
Like-
but
like
one.
everybody who has had a heart attack, there's a class action advertisement. You've had a heart attack, have you had a scan over the last 10 years? Contact us. If you had calcium score and they were not reported, we're gonna go and prosecute that healthcare system
No,
for not.
The answer is because what the court may very well do is say, this is an individual situation. Should this have been done in the individual case, it does not become a class, because the individual facts within the individual case would be determinative, rather than saying everybody in the situation, because everybody in that situation would not have suffered the consequences of the failure to get them that information.
Just because 5% had heart attack, the rest of them didn't have heart attack, so that
Then how could they be part of this class? Because the class.
they were not all hurt.
They were not hurt. And then the court would, because it happened to me in a given situation, that we found 2 neurosurgeons with 300 cases of unnecessary surgery. Litigation was brought on behalf of about 60 of the clients. The court made us look at the individual injuries that each individual suffered as a result of the unnecessary surgery that was done on all of them. Even though it was the same malpractice, the individual injuries were different. So it would not constitute nor form a class.
Hold on, how, just because I'm confused whether I'm understanding this properly.
Yeah.
The way the advertisement is structured in Washington DC, it's calling on people who, one, had have lung cancer diagnosed, are in a primary care system, and were not scanned and fall within the guideline. And that is a different group of people. They all got lung cancer. They all were not referred for screening. They were not screened, and they therefore now have lung cancer.
This
And what-
case is even easier. They already had a scan,
They did?
a CT scan. The calcium was there. They were not notified.
Right.
Now they have a heart attack. Some of them died.
And I'm saying that they may run afoul of a situation where it is determined that it's individual responsibility. In other words, what is the individual damage to the particular individual as a result? The
Well, if they
class
have
may
lung
not-
cancer and they would have been operated on and not had it. I mean,
Yeah,
if
but-
you just focused in on those who,
Okay, I'm gonna give you
Yeah.
2 examples. I'll give you an example of a 30-year-old mother of three who should have been scanned for whatever reason, was not and dies, versus an 80-year-old man who has cancer and dies. The damages are not the same. And this is where the court may have a problem just saying, I'm going to accept this as a class.
But isn't that partially a function of some very negative Supreme Court decisions that have made it much harder to pursue a class action?
Well, the courts don't like class actions.
That's right.
So whatever the law is, I have to live with that law, whether I like it or not. And then they,
Sorry, because,
So-
yeah,
Okay.
Dr.
Can I
Casarini.
address that?
So I had one comment. When Bob and I went down to the very first time from the Cancer Society Roundtable to talk about lung cancer screenings, this goes back a number of years. We thought they were going to be coming at us with radiation dose and what do we do with the nodules? Their number one concern is what you're all talking about, which are the other findings on the exam. It's so critically important to family medicine to know what to do. The ACR pulled together all its white papers, and they called white papers because there's not a lot of evidence behind what to do with all the incidental findings, and put them into a one-pager document for primary care practices, nurse navigators to have at their fingertips for lung cancer screening about what to do with all the stuff that's in the report where there's no answer given. What do you pay attention to, and what can you actually ignore? But my question for the panel is, there are a number of companies now out there that are offering to apply algorithms into your PACS database. Search all your examinations, say all your chest CTs for coronary calcium or for pulmonary nodules, which may or may not have been reported by the radiologist, which may or may not be significant. What is your perspective on that from an ethical and legal consideration when applying tools like that? For a health system, there's a win because maybe it'll generate a lot more follow-up imaging that wasn't done. So they're looking at it through a financial ROI. There's the patient side of it, which is maybe you're finding something that wasn't found and it was actionable. And that also makes people wonder about medical legal risks that it wasn't reported. And then there's a whole lot of other stuff behind it. So what's your perspective on like going back into the medical record, which for radiologists are the PACS, the images themselves, to find things that weren't reported in a systematic manner?
If I could, I'll try to give you a quick answer. I think that if, in the case of the algorithm to identify coronary calcium on previous CTs, I am all in favor of it because we know that people have a worse prognosis if they have a high calcium burden. And there's a window of opportunity, the patient's still alive. And we believe, even though there's no clinical trial to prove it, that intervening would improve their prognosis. So I'm totally behind that.
But of course, there can also be, well, quote unquote, false positive findings, right? That you are going to run after things that will lead you nowhere, maybe unnecessary procedures, unnecessary surgeries. So there's also a downside to this. You're going to find out important findings, but also futile findings.
Possible, but rare, if you choose a good algorithm. The false positives, especially depending on where you calibrate or where you set the threshold, are very infrequent. You know, there's a risk
We have
to the patient of
Louis
not.
up front that's been waiting, so.
Yeah.
This gentleman's been waiting for a long time.
Thank you. I have a small question for the panel because we are here to discuss also ethical side of things about the notion of risk. How do we human understand the notion of risk? If you get a 5% chance or a 7% chance, how good are we? I'm very bad at it personally. I don't know. So that's my question.
Pick in between.
I'm going to go with Dr. Martin.
I'm certainly not an expert in it, but generally speaking, human beings are rather bad at probabilistic interpretations of probabilistic outcomes in the future. We're not good at it. And it takes a great deal of effort. I mean, we run into this in research all the time. When you talk about relative risk and this and that, you know, the odds of being hit by a bus on the way to the outpatient clinic is usually higher then some of the risks we're putting in informed consent. But then don't talk about, you know, obvious risks that need to be discussed. I think people just have a bad way of doing it, and it's a problem throughout the profession. Again, not simply limited, but I think it's got to be taken into account when we do think about how we're communicating and how we're writing and what we're putting in the medical record that people are reading. But I think you have to start off with the idea that humans don't do a good job with this at all.
And
Thank you.
the last question, Dr. Granis?
Follow-up question that Cheryl asked about why it's so hard to sue. And very few people know, if they haven't read Glance's article, Stanton Glantz, in 2013, with another individual, wrote an article in the Iowa Law Journal explaining why it's almost impossible to sue a tobacco company in a class action. And the answer that they came up with was that the law was written by the tobacco industry in the 1970s, and it was adopted by the American Legal Association, which again is an organization I had never heard of before, but apparently is very, very important in deciding how legal cases can be adopted. So I urge everybody to read that article. It's about 40 pages, but it's just packed with devastating information.
Thank you, Fred. Very important. So we're out of time. And so I want to thank all the panelists. This is an exploratory section. And we've answered very few of the questions, according to Dr. Healton, and I agree with her. There's more questions out there. But we have agreed, I think, is that communication is excellent, and asking the participants of the screening process, what do they want to know, is also seemed to be mandatory. And many of the other things with AI, with Cures Act is evolving. And so we're going to have to come back to this, because pretty much we're in a position where we could write things that might be paid attention to in terms of coming to some wisdom in this very difficult circumstance. So I want to thank you all. It's a great session, and we move forward.